Well, good evening, everyone. I do love it when people hop onto our live broadcast nice and early. This is wonderful. Already 39 people logged in to watch our amazing broadcast tonight. Want to say hello to Brenda Jungworth. Hello, Brenda. Hello as well to Kirk Huntsman. It's nice to see your name up there, Kirk. Morris Stewart, hello to you. If you are just logging on right now, we'll be getting our live broadcast started in about 2 minutes from now. But if you are logging on, please go ahead and introduce yourself. Tell us your area of specialty in medicine or dentistry that you're working in and where you're joining us from across, whether it's Canada or the United States or around the world. We've had people all around the globe logging in and watching. So it does help to create a really rich conversation. Christina Fuller, hello to you, joining us from Connecticut Dental this evening. Welcome. It's nice to have you with us. Continue to introduce yourself. I'll bring your names up. I'll bring you into the conversation. We welcome comments. We welcome questions. So it helps with engagement and it helps with our experts tonight. Hello to Emily Wang, joining us, a pediatric dentist from San Francisco, California. Lawrence Kotlow, hello to you. Hi, everybody. A pediatric dentist. Welcome, Lawrence. I think Lawrence, I recognize his name. I'm starting to get to know some of these names as we do more and more broadcasts. Welcome to you. Continue to introduce yourself. I'm sure that our experts this evening, Dr. Heit and Dr. Whitman, probably recognize a lot of names. Stas Pavlenko joining us tonight from Edmonton, Alberta. I hope I'm getting that pronunciation correct, from Alex Pavlenko Dentists. Christina Fuller says, I work for Vivos Practice in Litchfield Hills, Family Dental. Hello to you, Christina. Continue to say hello. I welcome you. I can see the numbers going up rapidly from those of you who are joining us for what promises to be a very powerful discussion tonight. We have two amazing experts with us, and I want to remind you that what makes this powerful is your engagement. Yes, I will be interviewing both of our experts this evening, but it's your questions and weighing into the conversation that really takes it to the next level. Well, look at this. Janster Navia from Philippines. I told you, people weighing in from all around the globe. This is exciting. Well, it must be like what, early morning there? Am I way off my time zones here? Hi, everybody. Winston Wing from Peace River, Alberta. Hello to you, Winston. That's my neck of the woods. We have Rashida. Hello, Manisha and Tammarie. Looking forward to hearing from you both. Want to be cognizant of time as you continue to log on. Our numbers are going up. Welcoming all of you. As I mentioned at the beginning, please go ahead and introduce yourself and where you're joining us from around the globe, because we want you to be engaged as well. On that note, it is time. Oh, more people coming in. Michelle Williams from Frisco, Texas. Hello to you, Michelle. David Wagner, who is joining us, a Vivos provider from Breathe Well, Sleep Well, Clearwater, Florida. Hello, Ivy Yu from Vancouver, Canada. Dawn is joining us. Dawn, you have to let us know where you're joining us from. I love seeing how people from all over North America and beyond, as we've seen, we have someone from the Philippines joining us this evening, are listening in to our broadcast. So on that note, I'm going to kick things off. So I say hello, ladies and gentlemen, doctors, dentists, researchers, scientists, and friends joining us this evening. Hello and welcome to our third live broadcast focusing on sleep apnea. Tonight, we are talking about the diagnosis and treatment of pediatric obstructive sleep apnea with dentist Dr. Tammarie Heit, along with board-certified sleep specialist and pediatric pulmonologist Dr. Manisha Whitmans. Our last two broadcasts have focused on sleep apnea in adults, and tonight We are switching our focus to recognizing and diagnosing sleep apnea in children. We're going to take a closer look at the impact that diagnosis has on their lives and on their development. This conversation will be rich in takeaways and learnings that could change lives. As I mentioned, this is our third in a series of ongoing broadcasts. My name is Carrie Dahl. I was a longtime television medical reporter as well as a 6 o'clock news anchor for many, many years. And I'm now a public speaking coach and podcast host. And I'm truly honored to serve as your MC and host for tonight's virtual event. We really do appreciate the time that you are taking out of your busy lives to listen in and participate in tonight's broadcast and learn more about the incredible work involving diagnosing and reversing sleep apnea in countless patients, both young and young at heart. We want this event to be informative and as interactive as possible. So please, we are encouraging you to join in this conversation. I will read your questions and your comments as they come in. You do not need to wait until the end of this broadcast. If there is something you want to ask of either expert, simply type your question in the comment box that is on the screen tonight. Also, make sure to grant StreamYard, which is the technology that we are using tonight, permission to use your name so I can read out who is asking the question and from where. In some cases, I do believe this technology is changing for the better, but it still may be possible that if you do not grant permission to StreamYard, you will simply show up as a Facebook user. The format for the next 60 minutes is simple. I'll begin by interviewing Dr. Tammarie Heit, who is based out of Edmonton, Alberta, Canada. She will talk about the treatment of sleep apnea from a dental perspective using the Vivos dental device. Following that interview, Pediatric Pulmonologist Dr. Manisha Whitmans will enter the discussion to talk about sleep apnea from her specialty. I will then bring back Dr. Heit to join Dr. Whitmans to further this conversation. Areas of discussion this evening include sleep disordered breathing and implications in children, a clinical diagnosis of sleep disordered breathing in children, and innovative treatment options available from trained dentists. There is a lot to cover this evening. And the research and work in this area is changing and impacting lives, and you will hear more about that momentarily. We are going to wrap up our evening and our discussion at 7 o'clock Mountain Standard Time. If you must leave early, or if you want to share this broadcast with someone who was not able to attend, a recorded version of this broadcast will be available on the website, thescienceofsleepapnea.com. So with that, let's dig in by welcoming Dr. Tammarie Heit, who has spent the last 25 years working in general and craniofacial dentistry and lecturing worldwide for 10 years to dentists, to orthodontists and medical doctors on her published research and on her findings. On that note, Dr. Heit, welcome to you. It is so nice to have you here with us this evening.
Well, thank you so much, Carrie. I really appreciate that. It's great to have you host this.
I am just looking forward to this discussion so much, but I want to begin here because I know how passionate you are about work in this area, your work, your research, about collaboration. Tell us why. Why is this so important to you?
Well, I'm first of all, I'm a general dentist, just working in the trenches. And probably a little bit different is that I was a nurse for 10 years. So, I've seen a lot of things over the years, a lot of, patients of all ages and the different treatments and things we do. And everybody's trying to make their patients better. And, we do need clinical trials and all kinds of university-based things. And I think that's really, really important to help keep our patients safe. But when some of the results you're getting in your own clinic on the ground show patients drastically improve, then it kind of behooves us as dentists to, document that and publish it and measure it and then get it going in the clinical trials. So I I hope there's people in universities and people who need research topics, and because there's a lot of research topic ideas I could give you. And my goal is just to make people better and to do no harm, and that's no different than any medical doctor or dentist out there. We really love our patients.
I want to stress too, you have done research in this area for a number of years, and you are in the midst of writing a book about it. Tell us more.
Well, I want to leave something behind, just from my perspective. And I would encourage every dentist to write their experiences as well. This is it's important for all of us to give our feedback and contribute to this, to the health of everybody. And the best way is to document it somehow. So I want to make a book that's made for medical doctors and dentists, because on the topic of sleep apnea, that is a medical condition with a dental solution. And many of the medical doctors don't realize what dentists can do to help. And a lot of people don't have a whole lot of training in sleep apnea and are a little bit nervous about it. And we want you to know that everybody's in the same boat. And the best thing to do is collaborate with each other, and everybody band together and start working together. And that's the best thing to do. So
that's where change happens, is through that collaboration. So with that, I'm going to dig in with my first question, but I also want to say thank you still to everybody who is continuing to introduce yourselves and saying where you're joining us from. I know that so many of you already collaborate and you know each other well because you work in the medical field. Continue to do that. And now at this point as well, I welcome your comments and your questions as I dig in with Dr. Heit. So I want to begin here of what we're seeing on the screen. You've shown, Dr. Heit, that optimal anatomy can lead to optimal function of the jaw in adults. So then, with that in mind, how can this information be used to help children?
Yeah, well, we were taught in dental school that, the upper jaw, called the maxilla, which includes the nasal airway there, as you can see, it can't be grown in adults, but, dentists have shown that indeed you can grow the upper jaw. And I showed that in the other couple of podcasts, but the upper jaw can be grown in adults by almost 2 cubic centimeters of bone volume. And when you grow that, it improves in symmetry and allows enough room for the teeth. So that's where the dental interest began. But what we discovered, because of more technology, is that nasal airway that's part of that upper bone also grows. And that would be important to medical doctors, because if you have a bigger nasal airway, and we can grow it in adults by 2 cubic centimeters, then, conditions that are related to upper airway resistance can also maybe be reversed. And then when the upper jawbone grows, the bottom jaw needs to come forward for the teeth to articulate, to speak, and to chew. And the tongue then comes out of the airway. So the airway is affected in 2 areas, both in the nasal airway and in the, the oropharyngeal airway. And the teeth can be all straightened. So if you can do that in adults, then a kid is already growing. This is just like putting gas on the fire. Mm-hmm. And there's a common misperception out there that, if somebody has a deficient midface, that they'll grow out of it or something. But in my experience, working in the trenches, people don't grow out of it. And any researchers that are watching this, there's lots of topics here, and part of my book is going to be to show some of the areas where we do need research, because this optimal anatomy leads to optimal function and optimal sleep. And there's a lot of us that are building sections of the big puzzle, and we have our section built, and we need to start connecting it all around to get the whole picture. So what I want to do is for the children. Really, that's our future. And I think we can prevent the development of sleep apnea in children. And in fact, now with the advanced technology, there's ways we can measure sleep apnea now in children that we never used to be able to do. So you can't diagnose what you can't see.
So before we get into that, I want to ask you this. What do you know that are the common causes of small upper jaw in children? Where does that come from? What causes it?
Well, one of the causes is this tongue tie. And, the tongue is very, very important. And when the tongue is tied, people don't necessarily die nowadays because there's all these bottles and tube feeding and everything. Nobody dies from a tongue tie anymore. But, when the tongue is tied, every single function of it is affected. So the first function is when the baby is swallowing amniotic fluid and we're still inside mommy's tummy. And that tongue is already swallowing aberrantly and swallowing backwards because of the tongue tie. And long term, if you look at an adult with a tongue tie, you'll notice the tongue is very enlarged in the back and very narrow in the front. And that's somebody who's been using a tongue tie their entire life to, swallow and then breastfeed and then talk. And then the job of the tongue is to grow. One of the jobs is to grow the upper jaw. And dentists look in people's mouths every day. And if you look under the tongue and see that it's tied, and then you see it's enlarged in the back and narrow in the front, and then you look up into the roof of the mouth and you see that the roof of the mouth is exactly the shape of the tongue. Many times the tongue will be scalloped and postured in between the teeth as that person is, posturing their body to open the airway. And so this can, a lot of signs of that can be seen in the teeth as well. So one cause can be a tongue tie. And I know Dr. Kotlow's on this call, and he should pipe up he's got a book called SOS for Tots or something like that. And Dr. Kotlow, that's where I learned how to release tongues in infants. Wow. And I believe every dentist should be able to provide that service to the people in their area, just taking a laser and releasing an infant's tongue. There's 78% reduction in the symptoms of the mother and the child who's trying to breastfeed. And so for that reason alone, patients are all over it, and the risks are very low. And if you learn to fully release the tongue, then you're in fact freeing that tongue up to do all the rest of the functions and try to avoid having a small upper jaw. And having a tongue tie could be compared to, I don't think they do three-legged races anymore, but when I was a kid doing a three-legged race, you can run way faster when your foot's not tied to somebody else. But you can sort of figure it out. And if you practice, you can get good at it and fairly good at it. But it is better to have optimal soft tissue anatomy there, that the tongue is very powerful in shaping the jaws.
Okay,
so that's one reason.
You mentioned, Dr. Heit, that tongue tie is one of the major causes of that small upper jaw, but is it always a tongue tie?
No, actually, there's a little video I want to show you. This patient was referred to me by a speech and language pathologist because the pathologist couldn't get this kid to talk. So the medical doctor, referred this patient to speech and language, and they tried everything they could and they couldn't get him to talk. So they thought, well, maybe there's a tongue tie. But when I saw this patient, her tongue wasn't tied. And in fact, instead, I saw her arches were narrow and she had a very deep bite, meaning, her upper teeth were overlapping her lower teeth. And all I did was put composites like white filling material, in this case, blue. And, she started talking. And this is a very powerful story here. So go ahead and play it. Oh, no sound.
We can't hear the sound at this time.
So basically the mom is saying, you can see the child has dark circles under her eyes, and, she couldn't talk. The mom said that immediately after she had the risers, She could sleep better, and she just felt better, and she started talking. And then when you watch her talk, you can see how near, how dark those circles are under her eyes, because this happened right away. And the mom said that the family could only understand 60% of what she was saying, and strangers could only understand 20% of what she was saying. But right after I put those little risers on her teeth, now everybody could understand everything. And I really love this video because the kid is talking and telling her story. So
let's give it another try and see if it'll play. We're going to go back and see. Sometimes technology doesn't always work. So let's see if that video will play. It doesn't want to cooperate with us.
No. Oh, that's okay.
Okay. Well, you summarized it for us, and the results that came, which were amazing. So let's talk now, Dr. Heit, about, are dentists really, or why then are dentists leading the way in helping these patients?
Well, I feel like in dentistry, we've had some really amazing technology that's really impacted our clinical assessment of patients. And I've had a cone beam CT in my practice for probably 15 years. And it's a low radiation 3D imaging. And we can take photos of the patient and observe them from the outside. But, this looks at the bones from the inside, and then we can see the animations there, like the poor airway is in red and in black where it's obstructed, and a good airway is in blue and white. And we can now kind of relate the mandible and the maxilla, the jaws and the neck posture, and all the craniofacial anatomy to the functional anatomy, the airway. So these patients are scanned sitting up or standing up. So, when you look at a patient like that, you got to wonder what it's like when they're laying down. And, dentists have a protocol that, they position the patient the same each time and make sure the patient doesn't swallow, because that, of course, will affect this result. But, I think it's some of the technology. Now, you can't diagnose what you can't see. And then all of a sudden, it was like someone turned the lights on when we got cone beam CTs. And I feel like every dentist needs to have one of these. As every dentist needs to be able to diagnose cavities or screen for cavities, they should also be screening for airway, because it's so connected to this area we work in every single day.
So how does this impact medical doctors?
Well, a lot of these, if an airway is obstructed, it can affect a medical diagnosis. And because we're talking about children today, if you take a look at the third circle there, these are cone beam images. But the third one is a child with Asperger's. And you can see this airway doesn't have any other color except black or red. All the other airways have at least some of the other colors in it. But this one is completely obstructed, and you can see the adenoidal tissues really big. And so I think, like, for medical doctors, if they had access to this, or a dentist that has this, then they could right away, say, well, maybe this patient should have a sleep study, and then we could treat the sleep apnea and see what the impact on the diagnosis of Asperger's is. And another common diagnosis in children is ADHD, and the symptoms for ADHD and obstructive sleep apnea are virtually identical, where it's really hard to differentiate between the two. And what's exciting now is we actually have, sleep monitors now, or sleep studies that we can do on children that are far more accurate and easier to wear and less expensive, and to help the medical doctors with the diagnosis, so that maybe we can apply some more conservative measures, maybe developing their jaws or something, to see how that would affect this diagnosis of Asperger's or ADHD, because maybe they don't even have that.
I want to dig further into that in a second, but first, you do have some examples of teeth development that actually impacted a medical diagnosis.
Yeah. Well, this fella, he came to my clinic. He's probably 10, And his upper jaw is so narrow that his bottom jaw is really trapped back, and it looks like he has kind of buck teeth, but really he doesn't. His front upper teeth are right. It's just his whole upper arch is narrow, and you can see the dark circles under his eyes, and his bottom jaw is too far back. But before his because I know that a small maxilla is affecting the airway in two ways, I did a sleep study, and his AHI was actually 16. It's covered up there by my name. But 16 is very high. It's severe in a child. Anything over 10 is severe sleep apnea. And so what dentistry can do when we have these sleep machines is we can conservatively just measure our patients before and after our treatment to see, what the impact on this medical condition is, and just carry on with our dental treatment, which is really to try to avoid braces in this area. So all I did was develop his upper jaw, which included his nasal airway. And you can even see the functional space. If you look at his nares there, you can see his nose holes where he breathes through are actually bigger, and his upper jaw is spread out so that his bottom jaw can come forward. And then, when I see that his anatomy looks more normalized, then we can do another sleep study, and lo and behold, it's 0. And the other thing we can do is we can do another cone beam CT and measure that airway right in the back of the throat and the neck. And if you go to the next slide, you'll see that that's what we did. And his airway increased by 4 times. Wow. So, we've got enough evidence here of anatomy. And now we're measuring the function, the airway function. And, there's some research ideas, for universities, how many different dental appliances do this? What works, what doesn't work, what works the best. Let's all get excited about this and start working together.
I want to bring in this comment from Larry Kotlow, who I know that you know, and he said, we need to evaluate children as early as the first week of life. It's needed to be part of my differential diagnosis. Dentists are the best place to begin with this, and need to have the medical community to work with us, not against us, which I know, Tam, you believe in strongly.
Yeah, and I've been lucky. My medical doctors around me have been totally awesome. Sometimes patients will say to me, they'll be upset. They bring their baby in, they've been struggling for 6 months, and the medical doctor might have said, well, it's a cosmetic procedure, or it's it's not tied or whatever. And I just right away tell them, there's not a lot of training in this, and I don't blame the medical doctors. It's like, keep the knives away from my babies. But it's just a matter of education. And I agree with Dr. Kotlow. When patients ask me when they're pregnant, when should I bring my baby in? I actually tell them, when you're pregnant, so I can tell you to bring them in right away, because that's the first thing I'm going to look for is a tongue tie. Mm-hmm. And Dr. Kotlow, there's many dentists that do this. I feel like every dentist should be trained in dental school to do it. It's a very, very simple and safe procedure. And, it really can prevent a lot.
Here's another one from Meredith Broderick. She says, in my area, the pediatricians and lactation consultants are really proactive about it.
That's fantastic. And I love that positive focus, Meredith. I think, we need to, all the medical doctors and dentists just need to find each other where they are and start building from there, because we're all on the same page. We want to help our patients. And I feel like the medical doctors, once they find out what it is we're doing and the impact we're having, it's going to be, they're going to be very happy, because they get really stuck with these patients that they can't help and that become kind of live a compromised life.
Okay, Dr. Heit, you've mentioned a number of times and alluded to sleep studies on children. How do you do a sleep study on a child?
Well, here's a 2-year-old. There's lots of different sleep studies out there. I like this one. It's from Sleep Image. And this one is great because it measures sleep quality. And I'll show you what that means and why it's important. Like, there's a level 3 sleep study where you need the nasal prongs and the chest things. And, that you can't sleep very well when you have all that on your face. And if you're a kid, you could get all tangled up in it and things. So they just would put something on the kid's finger, and that's not as accurate. But this one has cardiopulmonary coupling technology, which can measure, the effect on the heart when a child's airway is compromised at night. So in addition to a bunch of symptoms the kid has, if you do one of these studies, I think I have a slide on, the next slide would show what a study looks like. And as a dentist, I'm not going to read this thing. I'm going to send it to a board certified sleep specialist for a report. But this is a sleep result on a 2-year-old little girl there. And the way I would tell the parents about it is the first thing we want to look at is the signal. And basically, you see 8 green rectangles there, and green is good, yellow is caution, and red is bad. So the signal is pretty good. If you were to subtract out all the yellow you see in there, you still have enough hours of data. And what's really cool is in the morning when the person wakes up, this is loaded onto the cloud. I can access it and say, just bring it back. You don't have to wear it another night. Or, if that little signal in the bottom is all red, then I can say, keep it, try again, it fell off or whatever happened. So then you can see in this child that she doesn't have sleep apnea. It's 0 and 0. However, her sleep quality is really poor. And that's significant because it's resulting in sleep pathology. You see there with the yellow and the red, fragmentation. She's actually having heart issues and poor sleep quality. And this is something that a dentist can then, send this report to the medical doctor. And then the medical doctor can, do a history and an exam on the patient and take this report and counsel the patient. And a lot of medical doctors aren't that comfortable with this, but the idea is to work together and find the specialists in your area. And that's what we're going to do today. I'm excited for Dr. Whitmans to really help her colleagues, and I want to help my colleagues, and we want to collaborate. And the dentists and medical doctors can really work together to help this child here, because, she's sucking her thumb. And kids are the smart ones. They're
hop in here, Dr. Heit. There's a couple of good questions I really want to get to from Sanjay. He says, since dentists are more familiar with the oral anatomy, at what age do you prefer to see a child for their very first visit?
Right when they're born. I'd like to see the infant to check for a tongue tie. And then there's a lot of signs and symptoms that how the jaws are developing and some of the habits the kids will do. So while their kid is sitting around, they might be putting things in their mouth like toys and sleeves and pencils and sucking on their lips or darting their tongue in and out. If they're mouth breathing, if they're breathing noisily, or they're really hyperactive, or when they start to talk, are they talking too fast or very, very slow, or do they gasp when they talk? Gasp for air or lisp. When they eat, are they a messy eater? Then you're sort of thinking, well, is that tongue tied? Are they bobbing their head when they're swallowing? Are they drinking a lot with their meals? And of course, while they're sleeping, are they snoring? Are they wetting the bed? Like seeing someone early, you have an opportunity to ask the parents all these questions. And the earlier you treat the child, the better. The brain grows the most between 0 and 6. So I like to see the kid the day they're born and just give the parents some information so that they can look for things. Yeah.
I've got a few questions I want to squeeze in before we get to Dr. Whitmans. Okay. Judith says, Dr. Heit, do you work with myofunctional therapists that can help you with tongue and breathing function?
Absolutely. Okay. That's part of it. Once if the tongue is going to be released. They need myofunctional therapy before and after the procedure. Some tongues are not tied, and the kid has allergies or a bunch of other things. And as I'm developing the jaws, the myofunctional therapist is really going to help me, because the tongue can help develop the jaws quite a bit.
JG says, what is the brand of this test? I think this person is referring back to that sleep test that you showed us with the graphic.
It's called Sleep Image. And if you go to the website sleepimage.com, or even better, probably what you should do is go to Summit Club. And that's what we want to do today, is give you some resources where you can learn a lot about this. And if you go to the Summit Club, Airway Summit, airwaysummit.com. And for this broadcast, you're going to use the code Manisha to get it for free. But you're going to learn all kinds of, like, how to find the signs and symptoms in a kid, about these sleep studies, how to get them. They're not expensive. They're easy to use, easy to talk to your patients about, and your team can do a lot of it. It's just a phenomenal way to practice dentistry.
Okay, one more question here before we wrap up with you. It comes from Rashida. It says, I have not heard of Sleep Image. Is it approved by the AASM?
It is FDA approved, and I'm going to leave that to Dr. Whitmans. The AASM, like, they're not proprietary, and I think that's really, really important. I think dentists have a choice to, they're free to diagnose within the scope of their practice. They're free to prescribe whatever oral appliance they feel is the best, and free to use whatever sleep machine is FDA approved. This is FDA approved, but I'm not sure that the Academy of Sleep Medicine endorses any one particular product that's better over the other. But I would look to them for that, and Dr. Whitmans might be able to give you some more information on that. I'm just saying that's the one I use and love. And in a clinical setting, it's fast, it's cheap, it's convenient, it's easy to show the patients. It works to help the medical doctors, and it helps us do the treatment. And then we can use the same fast, easy, cheap evaluation to evaluate the effect of our treatment, in addition to the improvement of the signs and the symptoms of kids. And these kids, in general, they have learning problems, they have issues at school, tummy troubles, earaches, headaches, all these different things. And you watch a child change and grow with your dental development. And if you can send them home with an easy sleep machine to measure the results of your treatment, then it's more than just some subjective result from the patient. You now have a measurable result. And I think this is an opportunity for people in universities and in research to, embrace this. But there's a lot more to it than just that. I just like the simple stuff.
Yeah, simple stuff. Incredible perspective tonight. Dr. Heit, we appreciate your perspective, but I know you just need a break and probably a drink of water. It's time to catch your breath. We appreciate all of your comments that are coming in right now, but Dr. Heit, you get to relax for a while, and I'm going to switch gears right now and welcome Dr. Manisha Whitmans, a renowned board-certified specialist who also subspecializes in pediatric pulmonology. Dr. Whitmans completed her medical training at the University of Saskatchewan, her residency in pediatrics, and her fellowship in pediatrics respirology at the University of Calgary, Alberta's Children's Hospital. She subsequently completed additional fellowship training in pulmonology and sleep medicine at the Children's Hospital, Los Angeles in California. After returning to Alberta, she developed the Pediatric Sleep Program at the Stollery Children's Hospital in Edmonton. Dr. Whitmans is a passionate and driven professional who is striving to improve sleep and patient care for children and their families. She has helped with the development of the current international guidelines on the use of polysomnography in pediatric respiratory and non-respiratory sleep disorders. Friends, please join me in welcoming Dr. Manisha Whitmans to our live broadcast tonight. It is so
Hello.
great to have you here.
Thank you, Carrie. Thank you for that beautiful introduction. And thank you to Dr. Heit for inviting me to the podcast today or broadcast today. It's really nice to be here. I think if I could leave some starting words is that it takes a village to raise a child, and sleep apnea is no exception. Whether it's a myofunctional therapist or a dentist or a sleep physician as myself or an ENT doctor, should surgery be needed, or plastics to take care of the tongue tie, or even a respiratory therapist to help with the breathing and CPAP, whatever that is, it takes a village. It's a team sport. So she is one and I am another, and it takes a bunch of different hands and a bunch of different people to raise a child.
Agreed. On that note, I mean, you too, as Dr. Heit, you're so passionate about this work. Why is it so important to you?
Well, I've seen it in all walks of life. I'm an affected patient myself. I have sleep apnea and a horrific tongue tie that was never corrected. So I'm the product, and I just think, wow, how much smarter and brilliant and more productive could I be if my tongue had been treated 50 years ago? But I'm passionate about it because I see it impact people in all walks of life. And it's a cradle to grave problem. No one is spared. There's this myth that, it only happens in adults and it never happens in babies. It's not true. No one is spared from an airway that doesn't function the way it should, either structurally, from a jaw perspective, or a functional point of view, from birth to death. We're all susceptible.
So let's dig in about the prevalence of it. How common is it? Pediatric sleep apnea. What are you seeing?
Actually, it's more common than you would think, as many as 1 to 6%. So at least one kid in a classroom is affected. If you look at the diagram that I'm showing, the little writing in the bottom is funny, but so accurate. Roses are red, violets are blue. Without your airway, you are too. Whether it's blue and, being sad or depressed or unhappy or sleep deprived or an insomniac, whatever. So remember, Dr. Heit told you about the upper airway in the jaw. Well, I'm a lung doctor, and we focus on the tree from, you notice that it's from the trachea down and doesn't address the top part. So clearly we have to work together, because she helps with this part and I help with the rest of it. Because the airway still, the breath and life has to get from the tip of the nose all the way to the air sacs. And we're all involved in that team to make sure that the breath and air gets to where it needs to do its job.
So on that note of collaboration, because you said clearly we have to work together, why is medical dental collaboration so important?
It's important because we don't necessarily understand the origins of all of this. If you look at the little boy up top, he has a long face from chronic mouth breathing, and there's a lady at the bottom that has a smaller jaw that's recessed back. And then after the jaw surgery, her jaw is pulled out where it's supposed to. We don't understand that. We know that sleep apnea runs in families. So if there's a grandparent that's affected, there's a 1 in 2 chance that their son or daughter is affected. And if the adult son or daughter is affected, there's an 8.5 out of 10 chance that the grandchild is affected. So it runs in the family, kind of like the color of your hair or your eyes. So in managing this patient, Dr. Heit showed you the son or the boy where she corrected the jaw, and the sibling was affected as well. So it runs in the family, and multiple family members can be affected. So when I look at the child, I look at their craniofacial profile and knock on Dr. Heit's door and say, hey, the tonsils may be big and there might be things that I need to address in the way of asthma or allergies or other things, but there's also a craniofacial part that needs your involvement. And if the tonsils are big, then it needs the ENT surgeon. So there's all these different things to think about from a structure and a functional point of view in evaluating the airway.
So that's all part of the actual diagnosis of sleep apnea in children.
Yes, and it's a bit more complicated because the history is surrogate. In an adult, the adult might say, "Oh, you know, I can't breathe, or I choke, or gasp, or my wife or husband complains they can't even share the bed with me because I'm so loud, or they want to cover me with a pillow." But in a kid, it's a bit harder. Parents might say, "Well, he sleeps in the basement, and I have no idea how he sleeps, except that he's really tired and can't function in the day." Or the kid's up constantly, and the little kids show up as behavioral insomnia of childhood. They keep waking up and just don't sleep well. And so, the parents are exasperated, and then there's behavioral problems resulting from it. So we look for clues, just like Dr. Heit does, to look for other features or other characteristics that might help point the way to the root cause of the problem. So the tongue tie is one, but big tonsils and adenoids, having allergies or sinus disease or asthma, craniofacial features like grandparents or parents, all those things kind of provide clues as to where the problem might be in the root cause.
Lawrence Kotlow says, why do you think that it needs to start with ENT rather the pediatric dentist?
I think it depends on where the child shows up. Because of the practice that I have, I get tons of referrals from psychiatrists where the kids have depression that isn't amenable to treatment. So they want to ask me if sleep could be impacting or influencing their depression. Clearly, some of these kids are older. I get consults from preschool psychiatrists because they're wondering about ADHD or, other even pediatric depression in as little as 3 to 4 year olds or ADHD. So I don't think it's a matter of why shouldn't it start with someone. I think it behooves us all to ask the question for the patient that comes to our table or through our door and say, "Hey, how's your sleep? And is there a problem? And what is it that I need to do to help triage you or manage you in the continuum of care?"
Mm-hmm. A question from Chester says, can you point out the allergic crease?
Yeah, there's if you look on the top slide there, there's a little line across the bridge of the nose that goes all the way across, and the dark circles under the eyes are called allergic shiners. And the kid, rubbing his nose up, that's called an allergic salute. When they do the allergic salute long enough, you can actually see this line across the bridge of the nose. So I'm giving you all my trade secrets. You can find these kids in a lineup, at the gym or soccer class. You can already tell which one of them are going to have troubles. These are good things to look for. Okay. It doesn't matter whether you're a dentist or a psychiatrist or a respirologist or a parent.
Like I said, now I'm aware of it too, and I'm going to be looking for these types of signs.
Right.
Okay, let's dig into the treatment options, Dr. Whitmans.
Before we just switch there for a second, I just want to highlight what Dr. Heit mentioned in terms of diagnosis. So part of the challenge is that the history isn't like an adult because they can't speak for themselves always, or the kids sleep and they don't know. So when the dentist or myofunctional therapist or whoever have you looks in the mouth, if the tonsils are ginormous, like to the right, and when they lay down in the dental chair and you can't see the back of their throat, it already tells you that the risk for sleep apnea is really high. So you're looking for these features that help point you in the right direction. The diagnostic part, there's different ways to diagnose sleep apnea. The gold standard is the overnight polysomnogram, which is sleeping in the hospital with 30-some stickers and sleeping all night. But the technology is evolving so much that there's more and more ambulatory type testing devices. And Sleep Image is one. It isn't CPSA approved or approved by the college yet, but the technology in terms of machine learning and artificial intelligence is a moving target. So even within the next 2 or 3 years, it might look very, very different. So when you examine the child in your chair, or if you're a myofunctional therapist or even a parent, the kid snores and there's big tonsils and you can't see the back of their throat, it behooves you to talk to your family doctor or talk to your dentist or your myofunctional therapist or whoever and say, "Hey, could sleep be a problem or not?"
Here's another question from Lawrence. He says, which comes first, enlarged lymphoid tissue, or mouth breathing?
that is a good question. I don't have an answer for you because I've seen mouth breathers where they have very little lymphoid tissue, or they have ginormous tonsils and don't always mouth breathe. I think whether there's allergies or other things that may mitigate that plays a role. I think the mouth breathing would certainly contribute to lymphoid tissue, but if they have allergies or reflux or other sinopulmonary disease, there could be other reasons for enlarged lymphoid tissue.
Okay.
Like that child that she showed with the Asperger's syndrome, that airway is compromised for sure. And if I were to see that child, along with the dentist, I might be inclined to refer them to ENT to see how compromised the size of the airway is.
Do you want to talk about treatment options now?
Yeah, sure.
Okay.
Thank you. Okay, and so in terms of treatment options, again, it's important to address the root cause. So in a really young child or a baby that's snoring, absolutely, the tongue tie could be a contributing factor. Usually between the ages of 2 and 8, it involves the tonsils or adenoids typically, but sometimes it involves other things, and it's about looking at the whole airway and seeing what's needed, whether it's expanding the maxilla, or some kids, even as little as babies, need CPAP sometimes. Sometimes it's anti-inflammatory therapy, sinus rinses, myofunctional therapy. It really depends. The treatment approach needs to be individualized because we're trying to optimize structure and function of the airway to help the child live their best life, whatever that might look like.
A great question here from Sanjeev, who says, at what age do you switch from pediatric AHI values for diagnosing mild, moderate, severe OSA to adult values? What about the 12 to 14 age group?
Perfect, Sanjeev, that is a great question. So mild sleep apnea in kids is AHI over 1.5 is abnormal based on an overnight polysomnogram. You can score using adult criteria in kids 13 and up. If they're in that 13 to 18 group, it depends on what I find. If they're really symptomatic and their AHI is 2 or 3, it's good enough for me, because in an adult it's AHI over 5, because the AHI is one of the markers. It doesn't tell you everything about sleep apnea.
Final question to wrap up with Dr. Whitmans is, how do you know that your diagnosis and treatment is correct?
Okay, I'm what I call a footpath doctor. So I like to look for easy things. I told you that this is a team sport. I told you it takes a village to raise a child. So these are 5 goalposts in my mind. We know we've done the right thing if we improve their sleep, so they no longer have insomnia, whether it's a child or an adult. They don't wake up at night. They sleep well. They're not restless. They're not choking or gasping or struggling to breathe. Their breathing during the day is fine. They're not breathless. They're not coughing, wheezing, short of breath. They eat well. They're not noisy feeders. They aren't slow to eat. They don't have reflux. They eat well and they grow well. So being too little or being too wide is also a marker of sleep apnea. And they have great development. They do what they're supposed to at the appropriate time frame. So if their 5 goalposts are met, we know we're doing the right thing. If they're not, go back to the drawing board and reevaluate, because there's something about the airway, either structurally or functionally, that isn't working for that child or adult.
Incredible perspective. And Janster, we're going to put this up at the end, but since it's come up a couple of times and I want to draw attention to it, if you want to schedule an appointment with Dr. Manisha Whitmans, feel free to call 58765-SLEEP or send an email to sleep4success78@gmail.com. We will repeat this, I promise, this phone number at the end of this broadcast, and I'll keep this up for a bit. But in the interim, I want to bring Dr. Tammarie Heit back into the discussion so that the two of you can ask questions of one another. Dr. Heit, I'm sure you were sitting there listening, you're nodding. Do you want to start it off with a question for Dr. Whitmans?
Yeah. So Dr. Whitmans, we're using, sleep image devices, which, by the way, I just kind of Googled around a bit, and if you go to vivoslife.com, that's where you're going to find out more about them. And apparently the technology is only available in United States and Canada. And the Vivo Score, it's called Vivo Score, and they're the only home sleep tests that are FDA cleared to establish sleep quality and diagnose the presence of sleep apnea in both adults and children. And apparently this output and reports that were independently validated, they're up to 98% correlated to in-lab polysomnogram tests. But I know there's something with that, and I think what I'd like to do is my thing is medical dental collaboration and non-proprietary. And so sort of the Academy of Sleep Medicine, can you speak to, how far do they go to be non-proprietary? What do they do to try to, if there's some really good technology that's out there, when do they ever recommend it?
Yeah, you know what? The problem with anything in science is that the science is ahead of the rule making that comes, or guidelines, right? I mean, Tesla already has some self-driving vehicles, right? What are the rules? Like even with cannabis, right? Legalization of cannabis. Can you consume it within how many hours of driving? Some of these rules come after as we learn more from the science. So the technology is amazing. The science from it is amazing. I like it. The challenge becomes that the guidelines and the committees that approve this technology to be used widely in the medical field, that they haven't made the mandates or rules. So the College of Physicians and Surgeons, even in Alberta, they haven't endorsed that specific technology, proprietary or not, to say that can be used for diagnosing sleep apnea. So it puts us in a bit of a pickle, because the technology is good and it can do the job, but the guidelines don't. The company or whatever, the regulatory body doesn't allow me to use it to make the diagnosis of sleep apnea. I think it's coming, and even for respiratory therapists in the community, they're only allowed to use level 3. And in fact, the College of Physicians and Surgeons say that you're not even allowed to use ambulatory testing in pediatrics to diagnose sleep apnea, and has to be a formal sleep study in a hospital. So I appreciate what you're saying. The take-home message is it's information. It's part of a puzzle. It reveals some information. It's important to put the context of the findings of the test with the patient findings to paint the whole picture of the story. The less of the puzzle pieces you have of a picture, or the less information you have, the more you're guessing what it is. The better the picture and the more complete it is, you can get a better appreciation of what is involved. So I'm not against the technology. I love it. It's brilliant. I use it. The challenge becomes how to find the place for all of that in the context of the continuum of care for pediatrics and even adults.
And it's only $5 to do a study. Like, it's just so cheap and easy. It's easy
I appreciate that. Just take home point, people will often wear a Fitbit or whatever and say, my sleep is this or that. The problem with this is this isn't validated in the same way. So if you think about the validity, sleep images, and it's perfectly fine. But when you look at a bullseye, you want to make sure that what you're measuring really is what it's measuring. So, the Fitbit or some of these ambulatory watches, they do give you information, and it can be helpful, but it's just more information. It's not validated in the way the real watches that we use in research studies with pilots or whoever, where they're like $2,000 or $3,000 a watch, and they're validated against overnight polysomnogram, right? So,
and I have a problem. Like, another thing I want to get to, I think, is really important. I've seen now that there's all these airway kids coming into my dental practice. I've seen children on just like major drugs, like antidepressants and anti-anxiety at the age of 2 and 3. And how do we get like there's side effects to these drugs. Like to put a child on Ritalin, for 15
Yeah.
years, their chances of university are lower. And what if that's the wrong diagnosis? What if it's really sleep apnea and it's not ADHD? Like
Right.
that's a part that bothers me a lot,
Well,
and parents.
and me too, right? I mean, it's the different faces of sleep apnea, right? It's the kid that has ADHD or the kid with depression or school failure. The first thing I ask is sleep. Is your sleep restorative or not? Case in point, I'm a sleep apnea patient myself. I've been on CPAP for a while now, and it showed up as ruining my academic career. I really struggled with, I was one of two in Canada at a time, and then things just fell apart at work, and I never realized I just had insomnia. So I'd get up at 2 and go to work, and that's how I coped for a long time. And I didn't know that I had a problem till it started to impact in other ways with, bunch of other things. And so sometimes it's even hard to know. And you're right. I think it behooves all of us, whether you're a therapist or a coach or a teacher or a parent, is this really ADHD, and could sleep be making the behavioral daytime stuff worse? What came first, chicken or the egg? So it's important to address that. It doesn't matter who it is, whether it's a coach or a teacher or a doctor. We all need to ask, hey, what's going on? Are we treating the right problem with the right thing?
Do you like the look of the results coming from my Vivos treated patients?
Yeah, it's what my hope and wish is that the studies by Dr. Guilleminault showed that removing the tonsils and adenoids wasn't enough, and kids that had their maxilla mandible expanded plus with the adenotonsillectomy, those had the best outcomes. So keeping that in mind, it is my hope, wish, prayer, and blessing that we will be able to change the trajectory for the kids and give them an airway so they can live their best life. And the patient you showed, he grew a bunch of inches after you expanded his jaw, and I managed the inflammation in his airway, and we would want that for everybody. So my take home message is, if you are shorter as a sibling or shorter than your parents because they should be bigger, there's something wrong in the physiology of how oxygen delivery and use in the body is not working, and that child or adult or teenager or whoever needs to be evaluated. So if there's sleep maintenance insomnia and you keep waking up, there's a problem, something with the airway, and you need to see someone that can help you.
Incredible discussion, ladies. We could keep going for another hour. There is going to be a 2.0 on this. There's a couple of final comments here from Sanjeev. He says OSA is underdiagnosed in the adult population, and I suspect it's even more true in the pediatric population. Yes. You're getting the 2 thumbs up. Lisa Babiak says life-giving, the life-saving information and treatment. Bravo, doctors. Mark Musso says great information. To both of you, heartfelt thank you for such a rich discussion. And Dr. Whitmans, love the humor you inject to everything you do, even though, the subject matter is so important and so life-changing. And to you as well, Dr. Heit, for the passion that you bring to this discussion about a collaboration between medical doctors and dentists, and the impact that it can have on lives. To both of you, I say thank you for sharing your beautiful time with us, your expertise, and your perspective. On that note, I'm going to return you to our virtual green room and wrap up with a little bit of information tonight. Thank you, Dr. Heit. Thank you, Dr. Whitman. So, and to all of you watching, a few closing notes tonight. Once again, if you are a dentist or a doctor and you do have questions and you want to get trained perhaps in the area, the best places to go for answers. Here is that number connected to Dr. Manisha's practice. 587-657-5337. Or as Dr. Heit mentioned, you can go to airwaysema.com, use the code Manisha, all in capital letters, and that will give you free access to that support. To all of you joining us this evening around the world, thank you so much for sharing your precious time with us tonight. Kay says, thank you for your awesome presentation. Patricia, I want to honor all of the comments coming in. My experience is that they don't want to hear it. CPAP is the gold star. Everybody has a perspective, but we want to get education out there. Tashi Hart says, thank you so much. Excellent presentation. Another thank you. The thank yous are rolling in so quickly. Once again, I mentioned at the beginning of this broadcast that if you would like to watch any of the 3 broadcasts that we have done to this point, visit this website, thescienceofsleepapnea.com. This is the 3rd installment of this broadcast. We have featured a variety of different doctors, and of course, Dr. Heit has been with me for the duration of these broadcasts. If you are interested in following along, because there's many more to come, I want you to mark your calendar for Thursday, April the 29th. 6 o'clock, Mountain Standard Time. We are going to bring back Dr. Cleet Kashida. I know many of you know his name. You're familiar with his work. Dr. Kashida is an academic physician scientist whose major accomplishments and roles include serving as inaugural president of the World Sleep Society, the World Sleep Federation, and the American Academy of Sleep Medicine. We had a live broadcast with him on April a few weeks ago. He's coming back April the 29th, and we're going to push this broadcast right over the top by bringing back Dr. Manisha Whitmans to join him. The 2 of them, and Dr. Heit is going to be on hand. So do mark your calendars for April the 29th. If you want to watch this broadcast, any of the others we've done, thescienceofsleepapnea.com. Thank you so much for your comments tonight. They continue to come in saying thank you. So many people enjoyed it. Thank you for showing up for us this evening and for sharing your precious time with us. And we hope to see you in 2 weeks from now. Thanks again, everybody. Have a fabulous evening.